Hello students, and welcome to chapter 17. This is your last part of chapter 17. We're going to cover Lyme disease and organ transplant organ rejection. Okay, so let's start with Lyme disease. It's not a true autoimmune disorder because the antibodies generated in response to the infection are directed against the organism, not to the soft tissue. So that's the big difference, okay? And usually this is initiated, this reaction, by the spirochete, right? It's called Borrelia burgdorferi. The spirochete is Borrelia burgdorferi. The organism is spraying to humans through the bite of an infected deer tick, also known as the black-legged tick, right? It is the most common vector-borne disease in North America and is a reportable condition. So be careful with the Borrelia burgdorferi, okay? Okay, so let's get deep into interprofessional collaborative care. Lyme disease is divided into one of three stages. Early localized disease, that's stage 1. Early disseminated disease, stage 2. Or late disease, stage 3. So first is localized, then is going to be dissemination, and then the late disease. In stage 1, the patient usually develops a bull's eyes rash known as erythema migrans. This is the standard, right? It's very significant. You can diagnose a patient with Lyme disease with this symptom. You see, when we talk about systemic lupus erythematosus, we have the butterfly rash, right, after sun exposure. In this case, is the bull's eye rash known as erythema migrans. And this is good to know. You need to know the difference between Lyme disease and SLE, systemic lupus erythematosus. Okay, so I'm probably going to ask you the difference in the symptoms, okay, in the final exam. And also you're going to see a low-grade fever. Other generalized flu-like symptoms may occur, such as myalgia and headache. So it's pretty common when we are having this type of reactions. Flu-like symptoms are going to be also present. Doxycycline, amoxicillin, and cefuroximide is prescribed prophylactically following a bite, right? Your doxycycline, amoxicillin, and cefuroximide. Azithromycin and clarithromycin can be used in patients who are allergic to penicillin. That's another concept that you need to master in terms of pharmacology. When the standard medications like doxy or amoxicillin or cefuroximide are not used, or probably the doctor is using azithromycin or clarithromycin, means that there is an allergic response to penicillin present. And this is important to assess is safety precautions. Again, in your NCLEX, anything related to safety, especially allergies to penicillin, is going to be present. With early treatment, most people experience resolution of symptoms within 20 days. If left untreated, okay, or if treatment is not successful, 3 to 12 weeks later, the patient may progress to a stage 2. So we have to pay attention. We have to take notes when the incident occurred. Ask the patient when the patient had contact, or is the patient suspects the contact happened, right? So you have to take notes. Symptoms associated with this stage include continued flu-like symptoms, as I mentioned before, and pain in the knee, ankle, and wrist joints. The knee, the ankle, and wrist joints. Dysrhythmias, palpitation, dyspnea, and encephalopathy may occur. This is big, encephalopathy, right? Problems with the brain. Stage 3 can occur months to years following initial presentation. Months to years. I had contact with the tick, with the spirochete, sorry, with the spirochete in 2015, let's say. And right now in 2024, I am having the reaction. The most common symptom associated with this stage are arthritis in the knee and radicular pain. So cardiac dysrhythmias or transient heart block may be present. Cognitive effects usually accompany this stage as well. So is, your mental state, your cardiac presentation, and basically if there is any history of bull's eyes rash. Okay, treatment in stage 2 and 3 depends on the patient age and disease progression. Antibiotics are often given, and admission for cardiac involvement is common. So there you go. This is your Lyme disease. We are talking about Lyme disease, your final portion on chapter 17. And then I wanna, before I start talking about transplant rejection, let's focus on this box 1714, Lyme disease, patient and family education, prevention, and early detection of Lyme disease. Okay, so to complete that the information for that particular disease, you have to avoid heavily wooded areas with thick underbrush, especially in the spring and summer months. Walk in the center of the trail, away from brush, trees, and weeds. Okay. Nowadays, there is a practice that everybody is following, is called grounding. And people, they are basically walking barefoot, in the forests, in the parks, because there is this theory about that when you walk barefoot, your electricity component in your body is going to improve. Therefore, the electricity is going to kill many agents that are in your body. Could be bacteria, fungi, viral, right? But you really need to be cautious, okay? And especially if the patient is having an immune system that is compromised with comorbidities, right? So walk in the center of the trail away from brush, trees, and weeds is recommended. Use an insect repellent on your skin and clothes when in an area. Again, I am just reading the ones that I believe are very important. Wear long sleeve tops and long pants when going into a wooded area. Wear closed shoes or boots and a hat. Check your pets for ticks. This is extremely important. We don't pay attention to this, but this is important. If a tick is found, gently remove it with tweezers by pulling upward with steady pressure to avoid breaking it. And then dispose the tick by putting in alcohol, placing it into a sealed bag, wrapping it tightly in tape, or flushing it down the toilet. After removal, clean the tick area with the antiseptic such as rubbing alcohol or soap and water. Okay, some of the recommendations for people and family members for early detection of Lyme disease. Now let's move into transplant rejection. Okay, transplant rejection. You are going to come across patients that had the history of transplant rejection, not only in the hematology oncology unit, in leukemia, okay, if you decide to work for oncology, and also patients that are coming for different visits to the PCP, okay, are going to have history of transplant rejection. So it is caused by general and specific immunity functions of a host recipient, right, directed against tissues and organs transplanted from other people. So it's the immunity of the host that is reacting against the tissues and organs from other people. Host natural killers, your NK cells and cytotoxic T cells are the major cells responsible for the destructive attack on transplanted organs, okay, and leading to host rejection of these helpful tissues. So because the solid organ transplanted into the recipient host seldom has a perfectly identical match of human leukocyte antigens, again, because the solid organ transplanted into the recipient host, right, seldom has a perfectly identical match of human leukocyte antigens. Antigen is a guess, okay, between the donated organ and the recipient, unless the organ is obtained from an identical sibling. The patient's immune system cells recognize a newly transplanted organ as non-self, okay? So that's the first part of this transplant rejection. Everything starts down there. The reaction, again, the new organ, okay? And the presence of the human leukocyte antigens. How is the reaction? What is the behavior of that HLA? Without intervention, the recipient immune system starts immunologic actions that destroy these non-self cells, leading to rejection of the transplanted organ. Rejection can be hyperacute, acute, or chronic. And I want you to remember this. The rejection can be hyperacute, acute, or chronic. Why we need to, because the reaction is going to be so different in each in each type. It's so different, and the nursing intervention is going to be different as well. So you need to know what to do. The doctor is going to prescribe medication, and this medication is going to be lifelong therapy that decreases the body ability to reject the organ. So the medication is going to influence, is going to transform, is going to modify the reaction of your immune system. This is huge statement, okay? Huge statement. The medication is going to, the immunosuppressors, okay, or the immune suppressive therapy is going to modify your immune system. Teach patients the importance of adhering to medication therapy, because there's no other way to survive after a transplantation, right? And teach patients who have flu-like symptoms following organ transplantation to seek medical attention emergently. So everything starts with the flu-like symptoms, as many of the other conditions that we discussed in chapter 17. So let's go with the hyperacute rejection. The hyperacute rejection begins within minutes or hours of transplantation. So hyperacute is minutes of hours, right? And it's a result of the antigen-antibody complexes that form in the blood vessels of the transplanted organ. So this is going to be the reaction of the antigen-antibody complexes. Hyperacute rejection, minutes to hour, antigen, antibody, right? Antigen is the gas, and the antibody is the soldier in our body that is going to reply to the gas, okay? To make easy for you to remember. The antigen-antibody complex adhere to the lining of blood vessels and activate complement. So this antigen-antibody is going to trigger a small blood clots to form through the new organ. Okay, so we have antigen-antibody immediately within minutes to hours of transplantation is going to cause blood clots in the new organ. And this is going to cause occlusion in blood vessels. So the clots are causing occlusion in blood vessels. And this is going to lead to ischemic necrosis. If there is occlusion, there is no perfusion, right? And it's going to cause necrosis. Also inflammation with phagocytosis of the necrotic blood vessels. This is very bad. Necrosis and phagocytosis of the blood vessels and release of enzymes into the new organ. The enzymes cause massive cellular destruction with the transplanted organ, okay? So this is the hyperacute rejection, minutes to hour, is the activity and how the response of the antigen antibody complex is going to cause blood clots. These clots are going to reduce the perfusion and they are going to cause an occlusion and of course a necrosis, right? So before we go to signs and symptoms of the different organs, depending on the organ transplantation, let's continue. The hyperacute rejection historically occur most often with transplanted kidneys, but it's extremely rare now due to the specific HLA matching, your human leukocyte, right? Your HLA, your human leukocyte, I forgot it, antigens, okay? So they do the matching of the human leukocyte antigen, and right now the transplanted kidneys are having less rejections. Symptoms of rejections are apparent within minutes of attachment of the donated organ to the recipient blood supply. We know that. So what is the intervention? We need, the doctor needs the process. The process cannot be stopped once it has started, and the rejected organ is removed as soon as hyperacute rejection is diagnosed. So intervention is to remove, right, the rejected organ. But the process of the response antigen antibody cannot stop, so you have to remove, okay? Now let's move into acute rejection. So in acute rejection, this rejection is going to occur within 1 week to 3 months after transplantation and can occur even years later. So most of recipients have at least one episode of acute rejection at some point following transplantation. This is a huge statement. So probably the patient had a transplantation in 2020, and then in 20 everything was okay, and then the rejection reaction is going to happen in 2024. Okay, and most patients have at least one episode of acute rejection. So all of the people having transplants at least are going to have one episode of acute rejection. The first mechanism of acute rejection is antibody mediated. Notice the difference here, guys. So in hyperacute, there is an antigen antibody, and here is an antibody mediated and results in vasculitis, another difference, which is inflammation of your blood vessels within the transplanted organs, okay? The reaction differs from hyperacute in that blood vessels necrosis, there is no occlusion, there is necrosis, and leads to organ destruction. Okay, so in hyperacute, again, happens in minutes. Is the effect of the antigen antibody, right? There's going to be an occlusion of the blood vessels, and this is going to lead to necrosis and inflammation. In this case, in acute rejection, it's going to happen between 1 week to 3 months and even years. It could happen, right? And then the most important participant is the antibody. And in this case, we are going to see vessel necrosis immediately, okay, and organ destruction. So the second mechanism, so that's the first type of rejection in acute rejection. And the second mechanism is going to be cellular. The recipient's cytotoxic cytolytic T cells and NK cells, natural killer, enter the transplanted organ through the blood, penetrate the organ cells, and start an inflammatory response and cause a lysis of the organ cells. So lysis is the destruction, right? So then if laboratory tests such as proteinuria greater than 1 gram per day or new increase in serum creatinine following a kidney transplant indicate diagnosis is confirmed via biopsy of the donated organ, right? So you're going to see your proteinuria in the urine, and also your creatinine, which is your most important marker. As I always say, creatinine is the most important marker for kidney functions, right? An episode of acute rejection after transplantation does not automatically mean that the patient will lose the new organ. Okay, so drug management at the time of diagnosed acute rejection may limit the organ damage and allow the graft to be maintained. So immediately the doctor is going, that's another, in the hyperacute, they have to remove the organ, right, that is causing that reaction. In this case, they are going to prescribe medication to keep the organ to the minimum so you can keep the transplant there. Now, the chronic rejection, that's the third type. The origin of this is related to chronic inflammation and scarring. So that's different. It's a chronic inflammation and scarring. The smooth muscles of arteries overgrow and occlude the vessels, of course, because of the overgrowth. The organ tissues are replaced with fibrotic, scar-like tissue, and function is reduced in proportion to the amount of scarring. So that's something else that you need to, when we are reviewing these concepts, try to visualize, okay, how this looks like. So you can explain, and probably you can draw, okay, visualize, not only keep reading, memorizing, visualize what's going on. In the chronic rejection, you have scarring, right, and fibrotic tissues. This type of reaction takes place months to years following transplantation. So you see, in acute rejection, also it could happen after years, right? But the first episode could happen between 1 week and 3 months in acute rejection. And then in chronic rejection, the reaction can happen between months to years. So probably doctors or nurses are going to debate, is it acute rejection or chronic? If you know your theory and you know that the chronic rejection is more like fibrotic, scar-like, and reduce the function of the transplanted organ, you can make a difference between chronic and acute rejection, right? Of course, in acute rejection, you are going to have necrotic blood vessels and destruction. So the function of the organ transplanted is going to be impaired. Versus in chronic rejection, you are going to have a diminished function of the organ, right? So this type of reaction months to years and persists as a response to chronic ischemia caused by blood vessel injury, the result of chronic rejection and unique to the type of transplanted organ. So there is another concept, which is the cardiac allograft vasculopathy. Is one of the top 3 causes of death of patients with heart transplant. Okay, this is a very common transplant, heart transplant. So remember the cardiac allograft vasculopathy. Okay, and these patients, this is a top 3 causes of death of patients with heart transplant who have survived at least 1 year following transplantation. At least 1 year following transplantation. Management of transplant rejection. Before that, let's analyze this table here, the signs and symptoms associated with organ rejection. You have different organs here and the signs and symptoms of the rejection. I want you first to notice that in most organs, you are going to see fever more than 100. That's common, except with the heart. I doubt, I think they forgot to include that. But with organ rejections, fever is going to be common, okay? And for heart, of course, we're going to have ankle edema, like we had on congestive heart failure. It's going to be hypotension, tachycardia, of course, diminished ability to exercise because we need the heart to provide not only oxygen, but also a good amount of blood to the tissues. And notice weight gain of at least 2.2 pounds because of the edema, fluid retention, right? Let's move into kidneys, fever again. And the swelling is going to happen in the hand, legs, or eyelids. Okay, and also weight gain this time is going to be 2 to 4 pounds in a 24 period. So that's a very significant difference, right, between the heart that you're going to have weight gain of 2.2 daily, and then the kidney is going to give you a weight gain of 2 to 4 in a 24-hour period. Okay, and diminish or absent urinary output also is significant. In terms of liver transplant, fever and tenderness or pain in the abdomen also check for tenderness, right, around the area or the organ that was transplanted. Now, lungs, you're gonna have fever again, and you know the typical symptoms of your lungs: dry cough, decrease in energy because there is a poor perfusion and interchange between oxygen and carbon dioxide, right? Decreased home spirometry also, this is significant. Tenderness, of course. Appetite, decreased appetite because we need oxygen to do different activities, including eating, and shortness of breath, right? Pancreas, of course, fever. Notice the glucose elevation, right? Tenderness or pain over the area of transplantation and decreased energy. So, we already reviewed the acute, the chronic rejection. And also let's talk right now about management of transplant rejection. So choices of drug therapy are dependent on individual patient and type of transplant. That's very important. The doctor is going to order based on your comorbidity, the type of transplant, the type of organ. And I would say also depends also on the immune system of each patient. Drug therapy is taken for a lifetime following transplant. That's very important. Any patient with an organ transplant is going to take medication forever and ever. And the immune system is going to be modified, period. Okay? All drugs used are immunosuppressive to some degree. Immunosuppressive to some degree, meaning that they are going to put your immune system to sleep. And teach patient about the increased risk for infection, of course. If you don't have your immune system working 100%, you're going to have risk for infection. Some drugs used to prevent infection, rejection, should not be used while pregnant. Okay, another important fact. So if the patient is pregnant, okay, some drugs used to prevent rejection should not be used while pregnant. So you need to discuss this with the patient if the patient has plans to get babies, okay? You need to discuss this ahead of time. Common example of drug therapy to prevent transplant rejection. I highlighted the ones that are very common in the market, okay? Cyclosporine. So you need to monitor for hypertension. These drugs are no joke, okay? They are no joke. And if you're gonna come across to these medications in the hospital, you must know these side effects and symptoms, okay? Cyclosporine, if I were you, I put it in my list of pharmacology drugs that you need to memorize. So you have to monitor for hypertension. 50% of patients taking this drug develops high BP. Remind that periodic laboratory testing for liver and kidney function will be performed. So cyclosporine, high BP, check liver, check kidney, okay? And because you can see through the blood work liver and kidney damage, you're going to see a decrease in the liver and kidney functions. Teach to avoid grapefruit juice. Ding ding. This can inhibit drug metabolism, thereby causing the serum level to rise 50% to 200%. Oh my God. Yes. So teach the patient to avoid grapefruit juice, and grapefruit is linked to other many medications, you know, in terms of how the metabolism is going to be. So keep an eye. Grapefruit juice. If I were you, I would do a list of medications affected by grapefruit juice. Okay, and this can inhibit drug metabolism, thereby causing the serum level to rise 50% to 200%. So in other words, this grapefruit can cause drug right? Toxicity. Tacrolimus, and if that happened, your liver and kidneys are going to be out of the game. Tacrolimus, another very popular, teach the gum hyperplasia, and neurotoxicity. Okay, neuro, your brain, your communication between the brain, your spine, and all your muscles. Okay, may develop. Gum hyperplasia, headaches, tremors, and insomnia are common side effects. So laboratory testing for kidney function will be performed. Kidney damage can occur while taking this drug. Again, kidney again, kidney again. Now, of course, corticosteroids teach about safety measures that can be taken to prevent falls and injuries, thinning because of the risk of osteoporosis, thinning of the skin. Osteoporosis with resultant fractures are possible with taking this drug. So prednisone, your corticosteroids, weight gain, also hyperglycemia. The immune system is going to be sleeping and can cause risk to hide infections, right? Cytotoxic drugs, drugs that are going straight to the cell and can cause toxicity. Very common, azathioprine. Okay, monitor for neutropenia. This is something that you must know. A patient with neutropenia, okay, is going to be affected directly. It's going to be seen in your blood work, in your WBCs. Thrombocytopenia, so low platelets, and neoplasm development. Neoplasm development, okay. Although it's rare, bone marrow suppression can be a serious concern. So this drug is the number one in your list, okay. You need to know neutropenia, thrombocytopenia, problems with the bone marrow, especially suppression. And this drug has been associated with the development of neoplasm. So they are treating you for organ rejection, but they are basically destroying your bone marrow. Okay, teach that nausea, vomiting, and pancreatitis may be experienced. These are common side effects associated with this drug. And then you have the cyclophosphamide. Teach to take it with food. Nausea and vomiting are very common side effects. Alopecia, so the patient will lose hair. Okay. Remind to keep hydrated and to report any changes in urinary pattern. And this is the important part. This drug can cause hemorrhagic cystitis and bladder injury. So hemorrhagic, the patient is going to start urinating blood. Okay, hydration helps to prevent these conditions. So why hydration? Because if you keep hydrated, the patient is going to eliminate somehow certain amount of the drug in your system. Okay, you don't want to keep, you don't want to accumulate too much of this drug. That's why it's cytotoxic. Okay, so those are the ones that I will strongly suggest you to memorize, okay, and to remember. Organ transplant recipients and end-of-life considerations. Some patients who have had ongoing concerns with rejection may eventually choose to stop immunosuppression. Because of these side effects, some patients, they are going to tell the doctor, you know, I'm done. I don't want to take any more immunosuppression therapy. This may be a personal choice, okay, or one that is made due to expense, also because the medications are expensive. Discontinuation of therapy does not usually cause immediate deaths. However, pain, fever, weakness, and delirium, all signs of acute rejection, can occur in patients who choose this option. So it might be a short topic at the end of chapter 17, okay? And probably you are not going to pay a lot of attention because organ transplant rejection is not very common, but the type of medications, the effects of the side effects post transplantation, and the medication side effects causes a lot of issues, okay, and these patients are going to be suffering before and after the transplant, trust me. Okay, so so palliative care, look what we are talking about. Okay, even after the transplantation, palliative care optimally discussed before drug discontinuation is an important option to explain to patients and family. Nursing safety priority. Here they are suggesting you to pay attention to cyclosporine, remember, uh, tacrolimus, and some other azathioprine, thioprine, cyclophosphamide, these medications that I mentioned previously, and the side effects. Okay, so we have a complete team that is taking care of these patients. Okay, you're going to have the doctors, the team of nurses, and everybody, social workers, case management, expert panel of people that are going to be analyzing, because each patient is different. Each patient, in this case, we cannot follow an algorithm like in hypertension or diabetes. And even with algorithm for hypertension or diabetes, um, things needs to change, because we have to treat patient individually, right? We cannot treat everybody with the same dose um, of metformin as an initial therapy, for example, right? So they are going to sit, this committee is going to discuss, you know, the comorbidities of the patient, how the immune system is, what type of organ is being transplanted, and what medication they should be recommending and prescribing. So with this, we complete chapter 17, and just focus right now on the topics for the exam 3 blueprint, and then for the final I may add some other topics related to chapter 17. Thank you so much.